Welcome to The Bone, the podcast that goes deeper. Here we cut through the noise and get straight to the core of the issues that matter. From real stories to raw truths, we dive deep into the conversations that shape our world and challenge our thinking. We're not afraid to dig in and get to the marrow of it all. Whether it's life, culture, or business in sports medicine, we're here to break it down raw and real. No filters, no fluff, just to the bone. With your host, Shelby Daly, we're getting to the bone. This is a clinically pressed, approved CEU podcast. Find the quiz to gain credit at clinicallypressed.org/courses. Clinically Pressed Company, making the complicated simple through results that give back. Find out more at clinicallypressed.org. Let's get started.
Welcome back to the Bone. Today we have Grace Savage, and I know Grace because she's the only other classmate I have in my doctorate program in my 12th, or it's the 12th cohort, and we are going to graduate in December 2025. So close. Yeah. Well, as I've gotten to know Grace, she has many interests and many skills, but today we are going to talk about CPR. So the topic of discussion, I was being witty, resuscitating your CPR response. So with her capstone, she is working on her company and teaching classes on CPR and different facets of emergency care. We'll get into that more into the show. But she is an athletic trainer with over a decade of experience that spans college athletics, outreach, and clinical education. She has dedicated much of her career to educating athletic trainers on minimally interrupted cardiac resuscitation and bridging the gap between certification and real-world readiness. She founded Savage Sports Medicine, PLLC, where she offers education emphasizing cardiocerebral resuscitation strategies, airway management, and clinical decision-making. So while Grace is here sharing her insights on CPR, scenario practice, team leadership, and what it really takes to be ready when seconds count, she's here to educate us more on why this is all important. So welcome to the show.
Thanks for having me. I'm so excited to be here.
Yeah. So emergency care is one of the biggest pillars for athletic trainers, but what is your favorite thing about what you do as an athletic trainer?
Overall, it's the ability to be a part of someone's journey. So early in my career was all about my athletes and being there for them and caring for them and just, doing what I could to support them and empower them to do what they needed to do. And as I've kind of transitioned later in my career, now it's more about supporting other athletic trainers. I still work clinically some and I treat patients, and that's still near and dear to my heart. But my passion has kind of shifted a little bit to what can I do to empower athletic trainers to feel more confident and more capable and just be ready to face whatever walks in the door, because as we know, we never know on one day the next what we're going to see. And so I'm really passionate about professional education on a lot of different fronts, but particularly on this front. And yeah, just being able to help people feel more able to do their job, more capable and more confident to do what they need to do.
Yeah. I think we're so concentrated on making sure everybody else is taken care of. Sometimes we don't have someone watching out for ourselves. So yes. I think that's one of the downfalls of our profession right now, but I think people are waking up. So yeah, it's pretty interesting. Definitely. So as I had mentioned, your capstone is working on your educational content, and right now it's kind of centered around the CPR and emergency care. So why is CPR so interesting and important to you?
Yeah, well, the heart has always been something that's been really fascinating to me ever since I dissected it in freshman year of high school. I was like, oh, this is cool. This is how they told me it works, and I can cut it open, look at it and see that that's how it works. And it, for some reason, it just kind of caught my attention there. And then undergrad accredited program, emergency care, it was just CPR, it was whatever. It's kind of okay, we're going to teach you this, you have to know it. doesn't have good outcomes, so we're going to teach you how to do it, and here we go. And then first recert was in grad school, and it was just like a challenge. I was like, okay, yes, I can answer the questions. Yes, I can do the skills. Okay, go. And there wasn't much else, like even emergency care from a clinical side, really at all there.
Mm-hmm.
And then I went to my first job, my first full-time job, and it was just on a whole other level. Shout out to David Stuckey and Wade Green and all the good people over there that just kind of built that program as it was. But they had really high standards for emergency care, for practicing, for the equipment that we had on site, for all of that. And I was kind of blown away. I was like, oh, I don't like know this stuff. Like, I don't know. Some of it was vaguely familiar from undergrad, but like I was like, oh, what? And then one year, it was a couple of years in, we were doing an IP event with our local paramedics.
Mm-hmm.
And they were talking about how they used a minimally interrupted approach, which at the time was like non-guidelines or are kind of separate from the established guidelines. And he just, like, we were in the weight room, and there's a whiteboard, and he just took a marker and was like, oh yeah, because the heart like does this, and this, and said secondary cardiac arrest, and it was just like 10 minutes. Blew my mind. I was like, why have I never been taught this? Like,
Mm-hmm.
what? The one thing, first thing, I'm a nerd. I was like, that is so cool. And then I was like, why? Like, there's no reason this should be the first time that I'm hearing this. This is not a ACLS concept. This is not some like way up here thing. It was just like a basic physiology of the heart and of cardiac arrest and different things like that. And so I was kind of like, why don't we teach this? But that was kind of just like in the back of my head. And then I saw a video of the tragedy that happened with Zeke Upshaw. Now, I have zero knowledge about what actually happened, what actually broke down, what actually went wrong. Like, I'm a complete bystander from that. But when I saw that, and I knew there was medical personnel there, I knew those were athletic trainers, and I'm sitting there watching this video, and like I'm just like bawling. I'm like, why is nothing happening? Like, what is going wrong? And I use that video a lot. Again, whether it's actually relevant or not, I don't know.
Mm-hmm.
But just every time I watch it, I get such a visceral reaction. Sometimes I get super angry. I want to throw something. Sometimes I get so sad. And it's just like, where was the breakdown? And then throughout the time, just talking to people and just kind of and I changed jobs away from the place that was really good with emergency care into a place that wasn't.
Mm-hmm.
And just being like, oh, that's not the norm. More the norm was kind of what I experienced before I went there. And I was just like, again, I'm kind of a nerd, I'm kind of an educator at heart. And I was like, people need to know. People need to take this more seriously. How can we make them take it more seriously? How can we fix any kind of educational breakdowns? How can we do that? And so that kind of got me started down this road. I really fell down the rabbit hole of the minimally interrupted techniques that the paramedics in Abilene were using, and that they taught me about. And so I felt like a lot of that could translate to the athletic training setting. And so I've done some work on that. I've talked on that as well. And then as those techniques kind of started to morph back into the guidelines and the science kind of started to catch up, it's less of like, oh, here's this other thing, and more of like, this is like how we need to approach CPR, and just like changing our mindset on how we teach it and how we learn it and how we practice it.
Yeah. Well, I think it's interesting that, we harp on how much time matters in this procedure, and we kind of downplay it in our re-education, recertification, even I think the first time somebody's taking the class. And then, good practice is practicing your EAPs, but I've never actually practiced a CPR. We've practiced, spine boarding, splinting, basically trying to make sure our air splints don't have holes in it was, the biggest reason why.
Yes. All important things.
But I remember this was in my undergrad, and I was in pre-athletic training, but we had, I think it was an adaptive sports class, basically. So they gave us topics that we had to teach towards the end of the semester. And so CPR was mine. And so I was like, well, it's boring just to bring out the mannequin, talk about it. So we kind of kept quiet on what our subject was. And we're going to do active warm-ups, how to activate, get ready for your practice, whatever. So we had everybody running through the dynamic warm-up, and then I collapsed. And then my partner was like, oh my God, comes over, checks my pulse, and is like, she's having a cardiac arrest event. What are we going to do? She was a better actor, obviously.
Yeah.
But then we pulled back the curtain, and we had all the mannequins and stuff, and trying to show that this could happen at any time. And we've seen that time and time again, just at athletic events in the stands. It's not going to be where you're actually looking at that it's going to happen most of the time. So I think it's great that you are starting to bring this into the realm of being prepared and practicing and identifying that we need to spend more time on these life-saving techniques.
And I think for something like this, that we know we have to have our certification, and every 2 years we have to go do the thing. And it's really easy the farther you get in your career for it to get kind of mundane, and to get just a box that you check, and it be like a thing. Yeah, I know that, it's whatever. And I just, it's really important to me to bring a little bit more weight to that, and be like, no, we need to take this not only just more seriously when we do have to do it every 2 years, but understand that every 2 years is not nearly enough to maintain those type of skills.
Well, and with all the changes, I guess for our non-listeners, what are the current recommendations? I know that there have been some saying that you don't do breaths anymore. What are the compression rates? What are we at these days?
Right. Well, the thing with the recommendations now is there's actually some room for clinical judgment, and that's where the breaths, no breaths kind of things comes, and that's where the integration of the minimally interrupted techniques have kind of come into for healthcare providers. It's actually kind of a weird gap, because they talk about it for healthcare providers, but also for untrained lay people, we teach them hands only, so that it's it can get a little bit muddy in there. But the standard that the AHA is saying still is 30 compressions, 2 breaths. Your compressions to be 100 to 120 beats per minute, allowing full recoil, at least 2 inches in adults, and compression depth. At the center of the chest, the lower center of the chest, area for hand placement.
Okay.
But we'll get into it later as far as the kind of side of well, if you're a healthcare professional, you can make these decisions, you can make that decision. But that's kind of just the standard of where we're at right now.
Gotcha.
Midline, straight out on middle.
And then have you ever done CPR? I know I haven't in 10 years of being certified athletic training, but have you ever done it?
Nope. In my 13 years, I have not. And that's also something that kind of drove me to be to take this seriously, and kind of helped me drive me down this rabbit hole. Is I was like, I don't want to be that person on the video that's not responding properly, whether it's on video or not. But I was like, this is not, of all the skills that we practice, you can go out there and you can kind of not do them right the first time, and be like, okay, you learn, and now I'm better. Next time you do it better, right? These is one of those that there's just not that margin for error, really, right? And so in my mind, I was like, I have to know what to do, and I have to make sure that I can do it right. Because if it does, I could go my whole career. Maybe not. But if it comes to me, that athletic environment, or driving down the road, I don't know. Right. I need to know what to do, because this isn't someone's sports career. This isn't someone's bone on the line. This is someone's life. Right. Yeah. And that kind of weight has always kind of hung on me of this stuff matters more than literally anything else. Sports don't matter. Even if you go down the road of okay, maybe function of that limb, it affects their quality of life, but they have life, right? And there are things like that, different kind of prioritizing. And this is someone's life. They're going to live, or they're going to die. What are we going to do about it?
Yep.
So,
Nope, that totally makes sense.
Comfortable, low profile, flexible, and easy to put on, the Vero ankle brace is simply the best ankle brace for those who move. And that's just about everybody. This brace is adaptable for any phase of injury recovery, whether you're recovering from an ankle sprain, require extra support for your day-to-day, or want to boost your performance. The Vero ankle brace delivers. The Vero ankle brace uses every movement and every step to give you extra boost. The 3-in-1 brace can be worn on either foot, making it the most optimal ankle brace for injury recovery and prevention. The removable stirrups, easy adjust Velcro, and breathable design adapt to your ankle as your strength returns, helping to protect you from re-injury. A dynamic support brace designed by leading orthopedic foot and ankle surgeons. The Vero ankle brace effortlessly adapt to your movements, offering dynamic energy return and support with each step. VeroAnkle.com. Check it out for yourself. VeroAnkle.com. That's VeroAnkle.com.
So what are the current standards for recertification for CPR?
right now it's every 2 years. You can, a recertification class is less than obviously like a first-time certification. There's some leeway out there as far as for just checking off skills or doing it partially online and going to do skills and things like that, but it's still just in every 2 years. 6 years.
So with this 2 years, why do you think that's not enough?
Well, studies have shown that you lose your skills anywhere between 3 to 6 months after training. So if you are only, especially again for a profession like ours, like, so again, we could go our whole careers and not have to do this skill, and yet it's a skill we have to know how to do and know how to do well.
Mm-hmm.
So for us that are not practicing it on the regular, the only time we're doing it is for 20 minutes every 2 years.
Yeah.
It's just not enough. It's
Yeah.
just not enough.
So you've taught a few classes. What are some of the gaps that you see that are reoccurring, that are commonly reoccurring when people are trying to relearn the skill, recertify, and all that stuff?
A big one is just, again, understanding the nature and the different natures, because there are different types of cardiac arrest. That's one of the big things that is not always taught, rarely taught, and understanding that there are kind of distinctly different types of cardiac arrest, and those should be approached slightly differently. So kind of the approach. And then honestly, just like overall skills. Like I've seen in a class, somebody open up the little trainer AED and just like stare at the pads. I'm like, there's pictures on them, and there's, maybe you haven't seen this, HA trainer that I have over here, but like they all have the same similar concept, sometimes it's quality of the compressions and hand placement and things like that, or opening an airway. From the skill standpoint, it's kind of all over the place. It's just rusty. It just looks really rusty a lot of times.
Just the flow of it's
yeah,
real bad.
It's just overall just like, oh yeah, you haven't done this in 2 years. But the biggest thing that I see is that they don't they're trying, they're kind of, racking their brain. I can see their little wheels turning to understand the steps of the protocol, because they don't understand what's actually going on. Because we're clinicians, right? So when we have our base knowledge of anatomy, physiology, and injury response, and healing, and things like that, we don't have to necessarily remember what do the books say that I do after an acute injury. What was this that, we just kind of know the flow of other things that are important, and we do things like that. But I notice in this aspect, there is none of that kind of base knowledge. So they're all just out here just trying to
memorizing.
Trying to remember that thing they memorized 2 years ago, and it's just kind of robotic, and it can be really not smooth or efficient.
Yeah. So with this lack of flow that may be happening after 2 years, how does missing the deeper knowledge impact clinical judgment in the moment?
Basically, it's almost like you can't make a clinical judgment. You're just trying to say, what am I, like literally trying to regurgitate, what am I supposed to do right now?
Mm-hmm.
Like there is no flexibility there. There is no room for you to be saying what needs to go on right now, because you don't know what's going on. You just know, oh, someone went down, I'm supposed to do this. Which again, for a bystander, for a non-medical person, you have to kind of keep it really simple so that people can remember it. And that's
Yeah.
totally understandable. And I think in all, overall, it's right to teach lay people that way. But as healthcare providers, we are just held to such a higher standard. And we just need to have a much better understanding about what's going on.
Yeah. So I know I'm bringing in doctorate themes, but
Of course.
how does the context play into a live emergency reaction compared to a practice scenario? I know that you may know the person, you may not know the person. Does
Right.
that play into how people react when a CPR situation arises?
I think it definitely can. It's always, if it's one of your athletes or somebody it can become maybe you're not as calm as you would be in other emergency situations, or for a stranger, you might be like, oh my gosh, this person. But I think overall as athletic trainers, we're pretty good about just keeping our head in emergency situations or in just chaotic situations in general. That's kind of our that. But for as much as we practice our EAPs and as much as we try to do scenario training and things that are as realistic as possible, you're never going to know exactly the scenario it's going to be. I just had a friend that had to spine board someone at a rodeo when lightning was like 2 miles away and they weren't clearing the stands. Like, you gonna practice that? Like,
Yeah.
no, sometimes you get just like really wild scenarios. And one of my favorite parts when I'm teaching a class, particularly I do a lot of like one-on-ones and one-offs for a lot of our contract athletic trainers, is we sit and we just shoot the breeze with those type of scenarios. Like, yeah, maybe we can't set it all up to physically practice it, but we can get some mental reps in. What happens if I'm over here? What happens if I can't get this off? What happens if the parents are all up in my business? And it's like a lot of it comes out of their brain, like a lot of creativity, whether they've been through something or they've seen something or they, they had a friend that went through whatever. They just bring it up and we just talk through it. Like, do this, do that. Sometimes there's an answer. Sometimes that's a judgment you're going to have to make in the moment. What do you have? And we talk about what goes into that.
Yeah.
But that's honestly sometimes my favorite part of the class. Like, what kind of random stuff can we think of to talk about and the things. And that's the only, again, we can only simulate so much physically, but mentally we can simulate a lot more. So like, what can we talk about? To kind of try to figure as much of that out as possible beforehand as you can. It's never going to be 100%, but you can get there pretty close.
Well, I had seen on Facebook somebody had posted a video from a mom that was like jumping the fence because their kid was injured on the field, and it was, they had the explanation of, it's my kid, I'm going to respond how I want to, it's my baby, and it's like, well, what do you have to do when you're doing compressions and having to beat off a parent behind you of, get out of the way, I'm trying to save your kid.
Yeah, and that's when you hope that you have some support from coaches or some other trained-ish adult bystander, whether it's an admin or somebody in the area, that's like can help with that. Hopefully that doesn't come on as you as the person actually doing the response, but you never know. And that's when like clear, direct communication, no room for error. I need you to go over here and to let me work, or even if that's to a coach, I need you to take them somewhere else. We need to allow some space, whatever. Things like that. Because, that can be hard to predict when people start coming or they see, and then they see you start compressions, and everyone at least kind of knows what that means, and they start freaking out, or they pass out, and you're like, oh, well, now I got another victim over here. Can someone please go check on this person while I'm pretty sure they're still, okay, I need to deal with this. Things like that. And that's just that's some awareness and some clear communication with the people around.
Well, and I think that's one thing we leave out in our EAPs is the crowd control.
Absolutely. That's 100% whether or not you have the crazies coming to you, like, what are you going to do with the team? You're going to let them stand there and watch? Like, where are they going to go? Are we clearing the stands? Are we clearing that part of the stands? Do we have a towel crew that comes up and makes a little barrier. Like,
Yeah.
it can be very specific to venues, and to your sport and to all the things. The best we can give you is you need to have kind of these basic guidelines, but the minutia of it is going to have to come from you and your understanding of your sport and your venue and the people that you have available to you.
Yeah.
I know I'm only going to have 2 other people. Well, then what does that look like? Or now I'm going to have to go get, an SRO, or I'm going to have to wait until I have to use a coach from the other side. I'm going to have to use, like, what are the resources available to you to make sure that the scene is as clear as possible.
Yeah. Well, and then even with the women's professional soccer
Mhm.
league, I mean, they just had one, I think last week.
Yeah.
She ended up having Graves' disease, so she just collapsed. And then we had the cardiac event. What was that? At the beginning of summer that happened for Angel City?
Yes, I think that was.
So I think, seeing those events, I mean, you never want to see them, but it did create more conversation for these cardiac events, collapsing, unconscious events, I guess, of, do you stop the game afterwards or do you keep playing also? So trying to make sure you have a plan for those situations. It could have been a more traumatic event also,
Right.
Not that people are losing their limbs all the time, but like,
right. No, or even, we've seen it with bone sticking out or a joint sticking the wrong way, and how the athletes respond to that and how they're so shaken. And it's like, can we ask them to keep going after this?
Yeah. Well, and, we talked about directing the field. I think people don't understand that's a big leadership characteristic of being able to keep calm, be able to communicate effectively while doing the skill and, managing everything around you. From the DAT, we've talked about it extensively, but I think people don't understand that you have to practice these things so people don't take it personally and then aren't doing their job, or they blow it off because they don't think it's important. So
exactly.
I think those are some of the underlying things that don't seem important but actually help the situation the most.
Definitely. When I was recently teaching a cohort of athletic training students, and having them kind of do compressions in pairs and things like that. And when I talk about high quality compressions, we talk about rate, and we talk about depth, and we talk about recoil. But I also talk about ergonomics. It's very possible you're going to be doing these compressions for a long time. So how you position yourself, it's not just, are you in the right place on the chest? It's like, how are your legs? How close are you to the patient? Things like that. And then also, I'm like, if you see someone's compressions not meeting standard, you need to say something.
Yeah.
And you as a person, if someone says to you, you need to not get in your feelings. You need to take that criticism and understand. And we talk about that kind of communication, that kind of accountability, particularly in a pit crew environment. If you're in a team environment where you're going to have several trained people there, like, holding each other accountable to quality compressions is so important. And so being able to have that kind of clear communication, being able to take that type of communication, being able to have self-awareness to say, maybe no one's communicating to you, but you're like, I know that I'm getting tired and my compressions are not doing well. I need to say, hey, in the next 10, I need a switch or something, very clear, very direct. When I'm running scenarios for my class, I don't let people say, hey, you go get the AED. I'm like, you either have someone's name, or you describe what they're wearing, what they look like, and you make sure they look at you and they know that you're talking to you. And then you better tell them where the AED is. Don't be telling them to go get the AED. Good luck. Right? It's in the red bag on the sideline behind the bench. It's on the wall at the other end of the gym. Right there, right? That's why we try to have these things marked and very visible, but you also need them to have clear communication, because especially if it's a non-trained person, they tend to be in a lot more agitated state in an emergency. And so if you're trying to let somebody do that, you need to have very clear and very direct communication.
Yeah. I think we forget how much energy and exertion happens when you are performing CPR. In the classes we do, maybe 2 minutes, just trying to get a few rounds. I think they have to have a test or a activity where you're just going till you drop. You have to get it into the mind of, you have to be efficient and you have to have a team around you that knows what's going on, or else it's going to fail ultimately.
Yeah. I mean, your EMS response times can be anywhere from like 5 to 10 minutes, anywhere kind of in that ratio, depending on where you're at, sometimes longer if you're in the middle of nowhere. It's like, do you know what it's like to give compressions for that long?
Yeah.
I tell people my fitness goal is to be able to give continuous compressions without needing them. But it's a real skill. And again, with this group of students that I was just teaching, I had them do continuous compressions and switch 200 and switch 200 and switch for several times. I did 3 rounds each person.
Yeah.
And they were sweating. People were taking off their jackets. People, and it's like, could be a reality for you. Again, that's in a team environment, so you have someone to switch, which is great. But even if I'm just one-on-one in a class and they're like, can I stop yet? And I'm like, no, you cannot.
Yeah.
Right? The scenario is not over yet. You shocked them and now we're going. You did your compressions, you got the 80 on, you shocked them, and now we're still going.
Yeah.
Because just for people to understand how long that takes, to understand how their compressions break down during that time, and to kind of understand how to feel that or how to sense that. And then if they can fix it, if you have a trained person, even a trained bystander nearby, like, hey, I need you to come do a minute or two, 100 compressions, so I can breathe.
Yeah.
Or so I can do maybe a different task. Again, that's communication, very, very clear communication about what needs to happen.
Yeah. So as we talk about the importance of keeping the compressions and the depth, why is it important for athletic trainers to understand the physiology of the mechanisms that they are performing on the patient?
Yeah, first and foremost, I think it just gives weight. That's a word that I use a lot. It gives weight to what you're doing if you understand what happens if you don't do it well. You understand what happens when you do it. It's not just general perfusion to the heart of the body. This is perfusion to the brain, right? So we talk a lot about that's almost as important as anything else, is keeping blood flow to the brain. So a lot of times we get saves, but people are not neurologically intact. And they either go home severely disabled or they don't go home at all.
Yeah.
And so maintaining that perfusion to the brain is so important. Also, as I mentioned a little bit earlier, the types of cardiac arrest. There are 2 distinct physiologies in cardiac arrest. You have your primary cardiac arrest, or we call that sudden cardiac arrest, or cardiac origin cardiac arrest. Something is wrong with the heart, and the heart stops due to that kind of suddenly, right? They were okay, and they were not okay. Heart was beating, the heart stopped beating. And then there's secondary cardiac arrest, also known as respiratory cardiac arrest, hypoxic cardiac arrest, asphyxial cardiac arrest. There's some different terms out there, but for some reason, the body stops being oxygenated, generally a respiratory issue, choking, drowning, drug overdose, those sorts of things. And you lose the oxygenation in your blood, which eventually affects your heart muscle because it's not getting oxygen, and then eventually goes into cardiac arrest from there. So those are 2 distinct pathologies because one has no oxygen available, and so ventilations and breathing is a more higher priority. And one they have fully oxygenated blood, it's just not going anywhere.
Yeah.
And that's where your high quality compressions are more priority. And that's when you have to start making that judgment of when do I need to start giving breath? Is it worth it to stop compressions to give breath at this time? What's going on? Again, there's kind of like a decision tree, an algorithm that kind of has to go into that. But if you don't even understand that those are 2 different pathologies, then you might not be doing the most effective intervention for either one.
Yeah. So, I mean, we talked about breaths, no breaths. For a layperson, if they are still giving breaths, would it hurt the primary cardiac arrest or the first cardiac arrest that you talked about?
Right. It can.
Okay.
From a layperson. That's why we tell that hands only is an acceptable response, at least in the first 3 shocks, right? So you have 2 minutes of CPR, you let the AD analyze, shock, 2 minutes of CPR again, analyze, shock. By the 3rd time, that's when you kind of have to start like, okay, maybe I need to start doing ventilations. Again, if you're a healthcare provider, you start talking about Have I put an adjunct airway, a supraglottal airway in? Do I need to, that's kind of when that kicks in. But from primary cardiac arrest, you're good for 3 rounds at least of compressions only, and then getting that AED on them and getting them shot.
Yeah. Okay.
And because not only do they again, they have oxygen, they don't necessarily need it immediately, but filling the lungs with air actually reduces the amount of venous return to the heart. And so then it makes your compressions slightly less effective because you have less blood in the heart to be pumped elsewhere to the brain, right?
Yes.
And so that's why it's really important. That's why it's really important to understand ventilations, to understand BVM use and proper BVM use. That's a big one for me, for athletic trainers, because again, we don't use it very often. And I'm not sitting here saying don't use it or we can't use it or we're not capable of using it. Not at all. But we need to understand that if we use it improperly, we're not just not being helpful, we're being harmful.
Yeah.
And so again, just adding that kind of understanding to those types of things, and so that we can make sure that we make the appropriate decision at any given time.
Yeah, I don't think I've ever been told about the first or primary and secondary cardiac arrest.
I hear that a lot.
Which it makes sense, but I mean, like, we have our water rescue usually is what we're learning, and then we have our dry land cardiac arrest that we're learning, but they don't really provide the connection point of, if they're drowning, obviously there's water in the airway, got to get it out. And then on the land, I was like, well, I think land, we don't have to do breaths anymore because they're on land, but
Right. No, it depends on, and it's a lot of the schools of thought is like, we don't want to confuse people. We don't want people to make the wrong decision.
Yeah.
Again, with lay people, that's kind of understandable. The studies have shown they have been able to tell the difference. But like in a healthcare provider, that's a pretty simple distinction. Like, were they going and when they were not okay, they unexplained collapse, okay, or did we choke? Did they drown? Do we suspect a drug overdose? Or did we come upon them? We don't know what's going on. They've been laying there for a while.
Yeah.
Like, that's a pretty cut and dry line.
Yeah. Right? When you talk about it, it's like, it's common sense, but you just don't connect the dots when you're in the class, really.
Exactly.
A lot of
then
assumptions.
Also things like, do we know why having a drop to shock ratio or a time of like 3 minutes or less is so important? Do we know about the phases of cardiac arrest? A hard cardiac arrest is in a really good shockable place for like the first 3 to 4 minutes. That's called the electrical phase.
Yeah.
But after that, then it starts to lose its oxygenation. Lose its glucose, and the twitching in the heart becomes less. It's a lot less responsive to a shock at that time. So, and then that leads to the talk about, well, if it's a delayed response, maybe a coach called you out there, you get out there, no one's doing compressions. You're like, what is going on? Right? Or again, you come upon someone. You have to do compressions to perfuse the heart and to balance out the pressures in the heart, because all the blood that was in the arterial system floods to the venous system, floods to the right side of the heart, swells the heart, and it kind of starts to push against the pericardium. Left side empty, right side full. If you shock a heart like that, you're not going to get a perfusing rhythm, and it's not going to get the outcome that you want. So you have to do high quality compressions. You have to perfuse the heart. You have to even out the pressures and do that.
Yeah.
But do we talk about that?
No.
Right? Sometimes we talk about, what scenario you do CPR first and then you go get the AED. We do talk about that a little bit, but we don't talk about why.
Yeah.
Right? Or what scenario that you're going to, that applies to, really, besides just coming upon someone that has no response.
Yeah.
So these are just like the little things that, to me, like you said, it just makes sense. You talk about it, you're like, oh yeah. Like, that's, again, just kind of basic clinical and anatomy physiology of kind of what's going on.
Yeah. So I'm not trying to get you on a hit list or anything, but what are the survival rates these days with an appropriate response? Have we gotten better over the years? Where are we with, the statistics and stuff?
Yeah. one thing that's actually a more complex question than you may think, because just the tracking is also really hard to sort through all of that data and to get, like, what does that mean? What does an appropriate response mean?
Yeah.
They don't track if the CPR was good or if it was started on time. There's EMS intervention, there's bystander intervention for some things. Sometimes they break it down like witnessed shockable, which is generally your primary cardiac arrest, or your unwitnessed non-shockable, that usually is a little bit more on the secondary side. Sometimes they break it down cardiac asphyxial, sometimes not. So like finding a number that's actually answers that question is a little bit hard.
Okay.
But overall, EMS intervention for a witnessed shockable cardiac arrest is around 30-ish%. But again, if you've seen one EMS system, you've seen one EMS system, right? So the numbers are actually a pretty wide range.
Yeah.
And also if you break it down by age range, children tends to be a lot more respiratory. They drown, they choke, things like that. You get this kind of 13 to 18 range. That witness shockable survival rate is almost 70%, almost. Like it's way up there.
Yeah.
But then you get to older, you get people with comorbidities, and that's different. And so there's a lot of different ways to break down the data, and then there's some ways that are just not there as far as, again, bystander intervention, quality intervention, what time. If a bystander intervention on a non-shockable cardiac arrest is like a hard category to find, they don't track that. Like, messy. Real world EMS kind of cardiac arrest literature can be very messy.
Yeah.
But we have some numbers to work with. King County, Washington, which is Seattle, greater Seattle area, they are considered the gold standard, and their survival rates are at least like 10% above everybody else.
So have a cardiac arrest in Seattle.
Definitely. Right. And then you see some places that are just, their numbers are in the basement.
Yeah.
So, but overall, they have improved in the last 10 to 15 years as they started to kind of integrate that compression emphasized literature that they were really kind of slow to integrate from the beginning, from 2000. So,
Gotcha.
Once that kind of started to merge, we started to see better results from an EMS side. Once they, in 2008, kind of the first time they dropped a big bomb, like not in an update year, with the hands only, we started to see improved rates from bystander intervention.
Okay.
Whether or not it's less likely that it was like quality and more just like more people were willing to do it. More people actually doing it. If they're like, oh, I don't have to give mouth to mouth. Okay, I can do that. I can push hard, push fast on the chest. Like, that's cool. And so we have seen, again, in the last 10 to 15 years, a kind of a trend up, which is good. But it's still, and again, it's kind of how you break it down. So I remember the very first time I was taught to use CPR, it's like, we're teaching you this. It's an important skill to know, but know that the outcomes are not good, and you know, you're doing the best you can, but they're probably not going to make it. It's basically
be
the
prepared.
way we were taught, right? Which there's value to that, and the reality of that, and letting people know that. But one of the pillars of King County EMS and the Seattle Resuscitation Academy is that no one in VFib dies. Right? Do they have 100% save rate? No, they don't. But that's their standard. So when we talk about things that are survivable, sudden cardiac arrest, the kid's in front of you and they drop and you have an AD on the sideline, I think our approach shouldn't be like, oh, we're going to try this, but we're probably not going to make, they're probably not going to make it. It needs to be, this person has no business dying. This is a very savable.
We're going to try everything we can.
Right. And so I try to teach from that way of, no, the standard is that nobody dies. The standard's not that, well, the numbers are bad and we're just doing the best we can out here.
Yeah. So with EMS response, it is a delayed response most of the time. Do we have any numbers on athletic training response and CPR?
Which I really wish that we did.
I'm surprised no one's tracking that.
It's such not that I can find. If someone out there, please hit me up. But because again, where are we? We live in the gray area. We're not in a healthcare facility. We're not always recognized as a healthcare provider on site. Do they know that we knew that we were doing, like, are we just considered another bystander intervention?
I mean, probably in the general data, yeah.
Right. It's because we're outside, because they also will sometimes be like, it did have an inside a healthcare facility, outside a healthcare facility, things like that, right? So we're like, okay, it was like in the gym outside of my healthcare facility, but I had all my stuff there. It's
Yeah.
like, okay. So we could definitely use some more data on that, which would be really great.
Raise the bar in 2025. Complete your BOC certification maintenance requirements early. Don't forget that 2025 is a reporting year for athletic trainers. Are you on track to complete your BOC certification maintenance requirements? Find out today by logging into your BOC profile at bocatc.org/BOC360. That's right, it's time, and this year is the year to renew your certification maintenance requirements. Check it out at bocatc.org/BOC360.
So have you thought of doing a position statement on this?
Yes, I think there would have to be, to make it all the way to position statement, I'm going to have to get some more data, because right now this is basically my opinion about the way that things should be taught.
Yeah.
And that's hard to come up and say this should be the way. I'm standing here and saying this should be the way, but to get does that make sense? Like, to get there, I don't know. But I do think we are making strides in that direction, like with the new EAP update, or the new EAP stance on how we need to be doing that and how we need to be practicing, how we need to be building those and making sure we have those. That definitely ties into that. But I would like to, I don't know how to answer this question. It wasn't on the list. Without getting in trouble. Like, it's hard because a lot of this, for people who are not aware, like even you're like more seasoned people, if they were not part of that kind of minimally interrupted kind of group that understood and experienced that, they still think that we're a little bit crazy out here. And that includes a big chunk of the AJ. And so then it's like, do I come up here and say, don't listen to them, or here, do something different? The problem is, it's not don't listen to them. It's in their guidelines that it's allowed, like minimally interrupted approaches, and that healthcare providers have the clinical reasoning to be able to determine the best response based on the type of cardiac arrest.
Yeah.
That's literally the wording in there. But they don't teach that. It's just in the guidelines.
Yeah. Well, and that's where the question off the cuff was like, well, should we create a position statement to talk about this and make sure that athletic trainers are integrating that into their CPR training some way? I don't think the major health or major CPR corporations are going to be able to do that. Right. But, providing pathways for continuing education on these topics, which you are providing, but
yes, on a bigger
this needs
platform.
To be talked about technically.
Yeah. And
concussion care.
I guess the answer to that is yes, because I have thought about that's one of the many iterations of what I was going to do with this project. Of like, do I write for maybe the ATEJ or like an educational technique? This is how we should be teaching. Yeah. But the thing is, I'm also seeing there are a lot of MSAT programs that do teach a lot closer to this way. Maybe not entirely, a lot of those, they tend to integrate paramedics and EMS into that education. You're going to get this type of information a lot more from those people because they are taught that and they understand that. And so that's how they teach other people. Yeah. But it's the research, it's the AT that's tagged but for the district to be the instructor and how they teach their ATs. It's the people that are already out there that like where that kind of needs to change, which is why I'm kind of on this
Challenging it.
campaign to put out continuing education and to make that available, because it's like, also, where do you look for that?
Yeah.
You know, there's not necessarily like an article on pericardial restraint, but it's in other articles about cardiac resuscitation, you know, and it's in things like that. And so trying to make that more available for the public, and the public as in the athletic training public. And so I definitely think that I want to make this information as available as possible. And I want to talk to whoever wants to listen about just the importance of this and of teaching better.
Yeah. And
So
that's why I wanted to have you on here, was to talk about it and hopefully connect people to you so that we can do a better job.
Even when I'm talking about cardiocerebral resuscitation and the specific protocols of an uninterrupted or minimally interrupted technique, at the end I'm like, if you don't use the technique, that's fine. But these concepts apply to everything.
Yeah.
Like understanding how important these are, understanding what stopping compressions does, and understanding how long it takes to build back up pressure when you're doing compressions. Your first compression, your second compression, your 10th compression is not quite actually as effective. You have to get there. You have to prime the pump. Things like that. Like these types of concepts are important no matter what school of thought you ascribe to.
Yeah. Well, do we want to talk more about the skills, maintenance, and scenario practice?
Yeah. Let's do it. Let's do it. Let's do it.
Okay, so adjunct airways and oxygen. Do we need to know that?
Yes. In a word, absolutely.
Simply, yes.
Simply, yes. Next question. No. It's a basic skill. It's well within our scope of practice. It is something that is in our educational standards. And there's really no excuse for not knowing the skill and being comfortable with skill and being able to apply it in the field. Like, there's been labs, NATAs. I know in SWATA, in our regional district, we had a lab, an airway lab. There's CEU platforms. You can make friends with your local EMS and ask them about supraglottic airways. Like, that's the skills are pretty straightforward. You can get a set of OPAs on Amazon for under $10. So from if it comes to that, like from a basic airway standpoint, cost should not be that much of a factor. Again, a lot of times your EMS can help you with that as well. If you want an iGel or you want something that's a little bit more harder to find, they can help you with that as well. But they are pretty straightforward skills that can make a difference in a response in an emergency situation. And so I think that it's really, really important. And a lot of people are intimidated by an oxygen tank. It makes loud noises when I open the valve. No, or you just don't know, right? It's fair. Yeah, we learned.
You always think they're going to explode. I don't know.
Exactly. We think it's going to explode. Which is fair. You got to handle them well. But like it's a basic skill that any athletic trainer is capable of. So I always try to encourage them, like, it's not as complicated as you think it is. It's not as scary as you think it is. It's not as expensive as you think it is. And even with the cost that is associated with it, that is worth it to have this available to you.
Yeah.
So,
well, and I think some athletic trainers, you see the spine board and it's gathering dust and you haven't used it for the 5 years you've been there. So it's like out of sight, out of mind. Do I really need that? I mean, spine board's easier to maintain, obviously, but, the AED, I think people understand the maintenance of that. But if you brought oxygen into it, do you think people would get it, or they would just let it sit in a corner and not maintain it?
That's the question. And it actually kind of comes back to the leadership and to your ability and willingness to take this as seriously as it needs to be taken, and to understand that it needs to be a part of your response, that you need to get a bag that it fits in so you can carry it to practice. You need to, like, those are things that people just don't prioritize, and it just needs to be higher on the priority list.
Yeah.
I was walking through a new high school, affluent high school in the area, and on the wall they have an AED and an oxygen tank right next to it, and it almost stopped the bleed. And I was like,
yeah,
oh my gosh,
perfect.
I was like, that is great. And the AT was like, oh yeah, no, I don't know how to use that. And bless him, I'm not trying to call out anybody, but I was like,
Hey, let me show you right now.
I was like, and honestly, it kind of broke my heart. I wasn't like mad or judging, but I was like, if it's one thing if you're out here and you're like, I don't have anything, I don't have the resources, I would love to, but I can't, those type of things. But if you have it available to you, then you need to learn how to use it.
Yep.
The internet is a wonderful place. The internet is a wonderful place, and if nothing else, it can teach you the basics.
Yeah.
Actually, there's, I think it might still be on there on the NATA Professional Development Center. There's Stuckey has a lecture on oxygen use and athletic trainers, and I think there's maybe a couple other people that have something out as well.
Yeah,
but there's stuff out there.
It should be free if you're an NATA member.
Yes, it should. But yeah, like it takes a little bit of effort, but if you have it on the right place in your priority list, then that effort should be worth it.
Yeah. Well, that's not gruffing on any of the programs. COVID was a hard time and stuff, but I had moved to a new job, and the third day on the job, I was there by myself because everybody was at a tournament, and one of the athletes laterally dislocates his ankle. And so I walked around the facility. I kind of know where everything is. I think I'm kind of savvy on, I should probably know that. They didn't really have an EAP written that I thought was up to standard, but at that point I didn't have it memorized either. So I was able to coordinate and navigate it. And luckily I accidentally parked in front of that gate that EMS needed access to, and I had my keys in my pocket. But, one of the athletic trainers who had recently graduated came back from the event, and she was like, I don't know what I would have done in that situation. And I was like, I mean, luckily it wasn't life and death, but how you are freshly out, that should be at top of mind when you graduate, of how do I try to reduce risk as much as possible and help things flow. You don't have to have all the knowledge on how to solve it or heal it, whatever you want to say, treat it, but you need to know those basic steps. And I don't know if we're actually achieving that repetition and practice like we should be in some of these programs or clinical sites.
Yeah.
I'll say that right there. Whatever.
Oh, you said it, I didn't. Well, just like from one job to the next, it was so starkly different for me. It is like that in programs as well, and how they value it, or maybe even the resources that they think that they have. Maybe they have great relationship with local EMS, and they come in, they talk, or they're having to go straight from their own knowledge and understanding and things like that. Or I think a lot of times maybe it is taught in the classroom, but then they go to a clinical site and it's not prioritized there, and so they don't see it as a value. The students don't see it in the real world as being valued and being practiced and being there. And so I know for me, if I was a student, I was like, well, they said in the classroom, but I ain't seen nobody doing it, so let's just be a classroom thing, and it kind of just falls out the ears, right? So I think that it's a complex problem, because we can teach it as much as we can in the classroom, but if they're not seeing it in the real world, then it doesn't carry as much weight.
Yeah. Well, and I guess talking about it right now, how many clinics, athletic training rooms, whatever, when you hire someone new, is it in the first week or two of orientation that you actually run through the EAP? I know I've been walked through the facilities and it was pointed out, but this is a whole new staff dynamic ultimately. There's the little kinks of older facilities. How are we not running through these EAPs and situational awareness within at least the first month of someone being hired? I don't think where I've worked that's ever happened before.
Nope. Same. And that's a valid point, and especially now with the labor crisis, like say in the university setting.
Yeah.
We got people walking in the middle of a season. We got hired going, and everyone's just kind of going everywhere.
Yeah.
And it gets lost in the sauce. And I don't know what to say except that it has to be better. Mm-hmm. Like it has to be here on the level of priority of here's your keys, here's where you find the gator, here's the water source.
Yeah.
Then it's like, and here's the EAP. We're going to spend 30 minutes and we're going to talk about it.
Yeah.
And we're going to go through it if we can. Like that just has to be, it's just a mindset change. That just has to be a non-negotiable. It has to, like I said, along with handing them the keys, you have to hand them this and you have to talk about it.
Yeah.
And if you're going in, maybe it's a whole staff turnover and nobody knows what's going on. Okay, then you have a staff meeting and you go site to site and you figure it out. Like that is, sorry coaches, this is an off day. We're shut down from this time to this time because we're going to make sure that we can take care of people if something goes down. Right?
Yep.
To me, that's non-negotiable. Like that's just something that just really should happen. There shouldn't be an excuse. We were all new. Okay, then get together and figure it out.
Well, that comes from delegation and leadership management skills. I think that's been a hot topic on a lot of social media channels of per diem athletic trainers or younger athletic trainers not going and introducing themselves to the other athletic trainer or even the coaching staff or the referees. And those are going to be your major players if something happens.
Yeah.
And then I've also seen some tips of if you're doing per diem coverage, with the Sharpie right on the inside of your wrist, the address, and then, who your contact is, because you're not going to sit there fumbling through your phone. Usually you don't put it in your phone anywhere and it's just in the email. Emails are so hard to search. Or you write it on tape and then you put it on your medical bag. So it's easy access to direct people. But it's just like those little things can save so much time and confusion. And, I think they're great tips that people are talking about ultimately.
Yeah, that's all really good. And it's all very, very site specific and situation specific. Because I work a lot of contract work or work with a lot of contractors as well. But it's a lot of school-based stuff. So it's also, where's the admin? Like, who's your game admin? It may not be as official as a standard medical timeout, but notify these people, introduce yourself to them. In Texas, we have some laws about like what needs to be present, who needs to be present, like what needs to be known at the time of a game start. So then making sure that happens and talking to the people. Sometimes district by district, they have rules about that too. And so that can be helpful to you because you are the stranger in the situation. So identify the people who are not the strangers in the situation.
Yeah.
Right? Who know where you are and know where the gates, or again, I'll be like, EMS that gate? EMS that gate. If I don't have a standard EMS or EAP, then it's like, okay, I'm going to get the main points right now. Like, what are we, who we going? I'm calling, you call it. Okay. Things like that.
Hey listeners, ever find yourself on the sidelines needing that one crucial item? Look no further than Nexus Sports Medicine. Nexus is your go-to partner for creating comprehensive medical kits and accessories tailored for athletic trainers in any setting. From high school fields to professional arenas, Nexus has you covered. These kits are designed by an athletic trainer with meticulous organization, ensuring that you're always prepared, no matter the situation. Stay ahead of the game with Nexus Sports Medicine and keep your athletes safe and thriving. Check out Nexus Sports Medicine at nexus-sportsmed.com. That's Nexus, Nexus -sports, SPORTSMED.com to find out more and get your perfect gear today.
So mannequins are kind of pricey. Do you have any tips on how people can practice their EAPs with CPR or just even practicing technique? What are some ways that you would recommend?
That is tough. It's easy enough to say there are cheap mannequins out there, which is true, but it's also been shown that they can be not as useful for helping teach if they don't give good feedback. So having feedback mannequins is really important. That being said, sometimes you have to get creative, but you can find them. If you're in a school system, you don't have any, maybe your nurses do. Again, make friends with your local EMS. Walk into your fire station, bake some cookies, okay? Say hello. I work at the school down the street. This is my name. Hello, right? And then you have that relationship. You can walk in and be like, "Hey, it's my time to practice my skills. Can I have one of your mannequins for 20 minutes? I'll stay here in the fire station."
Yeah.
Right? Or they might be. Sometimes they'll be like, "Yeah, take it. Bring it back by the end of the day."
Yeah.
We've done that with the Lucas device that we needed for a thing. They were like, "Oh yeah, here, just bring it back." Okay. But that doesn't happen if you don't have a relationship, right?
Yeah.
They won't do that for a stranger off the street, probably, right?
Yeah.
But they will do it for you more times than not. If they know
and
you.
it's even just building that relationship of being comfortable with your EMS and them knowing who you are because they'll be at the event, especially if you do football. I'm sure there will be an ambulance on site, or if they have to respond, you already have that established relationship, and it's not the competition of egos that we sometimes see. And you can actually educate them on what an athletic trainer is, which is one of the big things we are still trying to do today.
Exactly. And then just, again, sometimes you have to get creative. If you're in your school and they have a nursing program, your nursing program has mannequins.
Yeah.
Right. If you're in any kind of educational system that has any sort of healthcare program in the high school or in the college setting, there's a good chance that somebody's got a mannequin somewhere.
Yeah. Even if you're a clinical site too.
Yeah, exactly. Like, it can be found. And then also in the end, even if that's investing in one dummy, one mannequin with a little bit of feedback on it, worth it, right? To keep those type of skills available. Yep. I think that's an argument that can be made. AD trainers, there's actually some apps out there that can like walk you through the verbal prompts and can do that. Again, not ideal. You want to actually be working with some sort of unit that's going to mimic what's actually going on. But that can be a basic thing to try. I love, since I am not paid, this is not a sponsorship, but I do love the concept of the new Avive AEDs that they can train at the same time in the same unit. That's just a game changer right there, because even now I'm struggling because I have one type of training AED, but most of my contract ATs use a different kind. And so I'm like, well, I need to get this other kind of training AED because it's just more relevant to them, for them knowing what it's going to look like when it opens up. Yeah. That being said, AEDs talk to you. They have pictures. Untrained sixth graders can effectively use an AED. That's been shown in studies. Like, yes, but we want to be able to use it quickly and efficiently and effectively. And so having some sort of device, or even just sacrificing some pads, open them up. If you don't have training pads, or maybe it's time to switch, and they're you're like, oh, okay, my pads are expired. I get new expired. Don't throw away the expired pads, right?
Yeah.
Open them up and use them to practice. Know what that looks like, things like that. So sometimes you got to get a little creative to understand that cost can be a barrier. There also are some community programs out there, especially if you're working with a high school or you're working with maybe an organization, a public organization. You can look and see if there's some grants or if there's some organizations out there that are willing to help come alongside with you, and maybe they offer training and they can offer it for free, or they can offer things like that. Depending on where you live, there's a lot of different types of resources out there that you can kind of make this happen.
Yeah. So with our DAT, we've talked about leadership. What are some identifiable skills that a leader in an emergency situation should have?
The biggest one, I think, is clear, direct communication.
Mm-hmm.
That's a big one. The great Ron Corson always says calm is contagious, right? So the ability to keep your head in a situation, which again, I think athletic trainers overall were pretty good at that. But I think being able to communicate calmly, clearly, directly, concisely during an event is really a main skill that's going to be, because people will respond to that. People who are freaking out, if someone is speaking clearly to them, like they know what's going on, they're going to focus on that, and they're going to kind of
hone into
that and be like, oh, that person knows what they're doing. Yes, okay, okay, and it's going to kind of focus them down a little bit.
Okay. So what's one practical step athletic trainers can take right now to start improving their resuscitation readiness between recertifications?
Biggest one is skills. Practice your skills at least quarterly. So at the very least, pulling out a mannequin, getting your compressions, getting airways in, you can do breaths, like minimum. Then going up from that, we talk about our annual EAP practice, right? Mm-hmm. So then make it more in a scenario practice. Maybe that's not every time that you're coming out to practice your skills. It's not a whole full-blown EAP practice, but at least once a year, if not more, getting out and doing that. And I'm not just talking, okay, the number one sport for cardiac arrest is basketball, not football. So a lot of our own EAPs, we go hard on the football side, which is fair. They have a lot of traumatic injuries, right? But we talk about site-specific. We need to practice our site-specific EAPs.
Yeah.
So maybe in a school setting that looks like, as we get through the fall semester, then we work on our winter sport EAPs, and we do our basketball and our wrestling and whatever else everyone's got out there in the winter, right? And then maybe in the spring we go on the baseball, softball fields and we talk about that, and we go through that and where those gates are. Depending on your setting, depending on your resources and your staff, it can kind of look different from place to place, but at least quarterly practice of your skills.
Okay.
If it's not a full-blown scenario thing, okay, but it needs to be at least quarterly practice of your skills.
Yeah. So we talked about oxygen and adjunct airway. Do you see any other new emerging skills in the emergency care sector that we should be aware of?
For athletic trainers, there's a big emphasis on the Lucas device and the external compressions and things like that. I think that's not probably ever going to really find its way into a traditional, regular, everyday athletic trainer kind of role.
Yeah.
At least not in the near future. I just think it's not practically feasible. But I do think that some of more of these compression emphasized techniques. I know Dr. Kyle's First 5 talks about doing compressions only for the first 3 rounds and things like that. So that those sorts of concepts and are kind of coming more into the athletic training setting. Sometimes people ask like, oh, this technique, it's so different. And I'm like, the thought processes are what's changing. We know like where to put our hands and how to do compressions and how to open the airway and give good breaths. Like,
Yeah.
I don't see that changing just a whole lot. I think that we have found more or less decently how that needs to be.
Yep.
But it's more about the protocols and the thought processes and the clinical judgments that come along with that. Although I will say, I found a pilot study from this doctor at Baylor from last year. And he's developing a little device that goes in the OPA, connects to oxygen, but goes down and delivers the oxygen at the pharynx instead of just with a mask with a non-rebreather or with a cannula.
Yeah.
So it kind of follows down that groove down the side of the OPA to the back. And they saw really good numbers with that, with oxygenation in the lungs. And it's staying steady throughout a cardiac response. And so that, I think, would be a reasonable, feasible, small little tool to be able to use for an athletic trainer using airways. Again, it was just a pilot study. I think he's still working on all the kinks and probably on production and things like that. But that was something I thought was really cool that would possibly be really applicable in the athletic training setting.
Yeah. Well, that's cool. I mean, you keep hearing of all these different little devices that are supposed to help with the applications. So I wasn't sure, those sound pretty cool, but you never know what's coming out next.
Yep. We'll see. There's a lot of really smart people out there thinking up of things and trying to make things better. So we'll see. It's exciting.
Yeah.
Exciting time.
Well, since we talked about a range of things that you could do with your project, the position statement or something like that, how is the best way to connect with you if somebody's interested in CPR and advancing it for athletic training?
Definitely. Best would probably be email. You can find me at savagesportsmed altogether at gmail.com. You can also find me on social media, _savage_AT on all of my platforms. But yeah, reach out, find me. I love to talk with anyone who will sit still long enough. So let's talk about it. Let's see what we can do to kind of change the way that we're thinking about this and to elevate our practice so that we are prioritizing and giving this the type of weight that it deserves in our training.
Yeah. So in summary, a 2-year recertification tells you what you know and checks the box, but regular practice shows you what you can do under pressure, basically is what we're talking about today. So well, thank you so much for being on, and I hope to have you on soon again. We'll talk about more stuff.
Yes, definitely.
Perfect. Well, yeah, thank you for coming on To the Bone, and we will have you on again.
Thank you so much.
That's it for today's episode of To the Bone. I hope we sparked some new thoughts, challenged your perspectives, or simply reminded you to dig a little deeper. Remember, life isn't just about what's on the surface. Sometimes you've got to cut deeper and get to the bone of what really matters. To the Bone podcast is a product of Daily LLC. It is hosted and produced by Shelby Daly, ATC, and Randy Daly. No clinical decision-making should be based solely on one source. While care is taken to ensure accuracy, factual errors can be present. For more on the show, visit www.tothebonepodcast.com. If you enjoyed this episode, be sure to subscribe, rate, and leave a review. Get involved in the conversation. You can find us at www.tothebonepodcast.com. Drop us topic suggestions or be a potential guest. We're all about connecting with you, our listeners. Until next time, stay curious, stay grounded, and keep cutting deep.